Almost all modern ventilators have a standard graphic display of pressure, flow, and volume. These graphic representations provide the clinician with a virtual representation of the effect of mechanical ventilation on the lung. In no way can these graphics give the precise picture of the internal lung mechanics, but remain of significant value for the clinician. Some ventilator modes may have unique features and settings. However, all modes of mechanical ventilation have three basic elements. Delivery of gas flow. This gas flow provides a volume, and a volume trapped inside an elastic structure such as the chest creates a pressure. Modes may vary by delivery of a different gas flow, targeting a volume versus a pressure, the time the volume or the pressure is maintained, and more. As modes become more distinctive, universally accepted descriptors become increasingly important. For the purpose of this presentation, modes may be characterized by the following: a trigger, either time or patient; the target, either volume or pressure; the cycle off, either time or pressure; and the gas flow pattern, either constant or decelerating. These will be discussed in greater detail throughout the presentation. In addition to the elements and characteristics of modes, each ventilator mode has settings. Briefly, we will discuss the basic settings for all modes. As manufacturers modify the names of the modes, almost all ventilators have the same names for settings. Each mode will target either a pressure, measured in centimeters of water, or a volume, measured in milliliters. Next, the duration of the pressure is set with an inspiratory time in seconds, whereas volume modes are primarily set with a flow rate in liters per minute. In addition, time may be added to volume ventilation as a secondary control setting. Based on the duration settings and respiratory frequency setting, an inspiratory to expiratory, or I to E ratio, will be calculated and displayed. Now a rise time, which may also be known as slope or ramp, may be set in seconds or percentage of inspiratory time. The rise time controls the speed of the gas flow delivery and the time to achieve the peak flow. Some modes provide a trigger setting in liters per minute, flow, or in centimeters of water, pressure. A trigger determines when the ventilator should deliver or assist with a breath based on a change in flow or pressure. PEEP, or positive end expiratory pressure, is available in almost all modes and is set in centimeters of water. PEEP will be explained in greater detail on the next slide. All modes have an FiO2, or fraction of inspired oxygen setting, and is measured in a decimal setting. However, FiO2 settings are expressed in ranges from 21% to 100%. All modes have settings for alarm limits, either minimum, maximum, or both. And finally, current ventilators provide enhancements to supplement almost any mode. Some examples include tube compensation, dual targeting features such as autoflow, and leak compensation. Positive end expiratory pressure, or PEEP, is essential in the management of respiratory care in critically ill patients requiring ventilatory support. PEEP elevates the baseline end expiratory pressure and maintains recruitment during the expiratory phase, where de-recruitment predominantly occurs. The ideal PEEP setting and its effect in animal models with acute lung injury and patients with acute respiratory failure have been widely studied over the past 3 decades and has produced a vast amount of information. However, to date, it remains unclear of how much PEEP to use in patients with acute respiratory failure that require mechanical ventilation. Modes of mechanical ventilation vary predominantly by the manufacturer, but may be distinguished by their control type. In this table, we will review volume versus pressure control types. Volume modes have a target to deliver a set tidal volume with a constant or fixed flow of gas. With this delivery, peak airway pressures may vary depending on the compliance of the lung, amount of flow delivery, and the amount of pressure required to deliver the set tidal volume. In contrast, pressure modes have a set pressure limit based on the pressure setting, and gas flow delivery is in a decelerating fashion. With a pressure mode, the tidal volumes will vary depending on the compliance of the lung and the ability to deliver volume based on the preset pressure limits. There are three types of gas flow patterns: decelerating, constant or fixed, and sinusoidal. In this discussion, we will review constant versus decelerating flows as they relate to mechanical ventilation. Note the decelerating flow reaches the peak flow rate rapidly and tapers or decelerates to the end of inspiration. Whereas in a fixed or constant flow of gas, the flow rate is maintained throughout the entire gas delivery period. Decelerating gas flows may be more comfortable for the patient and more beneficial to meet the flow demands of a patient with respiratory failure. Constant gas flow is seen with pure volume modes of ventilation, whereas decelerating gas flow occurs with pressure modes or dual-targeted modes, which we will discuss in greater detail later in this presentation. The type of gas flow delivery may have an impact upon patient work or breathing in different disease states. In this study, the effects of pressure control versus volume control assisted ventilation on patient work of breathing in acute lung injury, ALI, and acute respiratory distress syndrome, ARDS, were examined. This was a prospective randomized crossover study of 18 mechanically ventilated patients with ALI or ARDS. Respiratory muscle power was measured in joules per liter to determine work of breathing. Results demonstrated a significant decrease in work of breathing in the pressure control group versus the volume control group. The belief is attributed to the responsiveness of the peak flow configuration and the higher peak flow rates of the pressure control modes to meet the patient's flow demands, whereas the constant or fixed gas flow delivery of volume modes are limited and may not meet the patient's flow demands.